Thanks, Sandy. I mean, that's really a problem that we often face, and I think we are very fortunate that we have a very close interaction with our virology colleagues. And I'm just going, before we open it up to the floor, I'm just going to ask Stephen Korsman, a virologist in our team, what is his approach? How should we interpret the IgM core? When do we ask for values?
Is this working?
Yeah.
Okay. That is a difficult question because it's easy for us at Groote because we've got virologists here. We pay attention to the subtleties of these tests. These tests they're not actually quantitative tests. They are qualitative tests, and above a certain index, you will call it positive. And it's only when you end up having a lot of experience with these tests that you start noticing the subtleties when a particular test is a strong positive and when it's a positive that you start to wonder about. Is it a true positive? Is it a false positive? And then obviously in a case like this, when the subtleties of the test can indicate the difference between acute hepatitis versus a flare-up. So you need to have a relationship with your lab. Your lab needs to have a virologist or someone who can interpret the subtleties of these tests. And the exact value would differ a lot between different manufacturers of the platform that you're testing the IgM on. For example, currently we would set the cutoff at Groote at 20, but if the test we used about 15 years ago, we would set the cutoff at about 8, because it's a completely different numerical range that we're working with. So you need to have that sort of information available, and it's difficult if you don't have a virologist there to interpret for you.
Thanks very much, Stephen. I think we had a question from Mike.
So if this was acute hepatitis B, what would the viral load be doing? Because you highlighted the high viral load as being like a clue. So I was wondering, what would you expect if this was acute hepatitis?
I think because Stanley's only been with us for 2 months and he's actually in GIT, so I'll take the heat. So, I mean, 14 million I think is very high. I would expect somebody who's jaundice, whose INR is going up, for it to be falling by this stage. I wouldn't expect it to be, that high.
Viral load in acute Hep B.
Yes, no, I would agree. When you're having a strong immune response, it's your immune response that is controlling the virus very well. So acute Hep B, when you've got that immune response, you're going to have a low viral load at that point when you're actually detecting it. Yes.
Thank you very much. Just wanted to find out from you, Prof. and Mark, the INR and the transition to the cardiac clinic in this patient, was that not a red flag?
Yeah, so if you look at that initial, he shouldn't actually been sent home. You saw that, so it's not really the jaundice, but what you saw was, and I think one also needs to remember the transaminases can be, they can be falling, but in fact it might be the liver's actually imploding. So you really got to look at that INR. And what was very concerning in him was that INR was rising. And I think in the patients that we look after, even if you've got acute hepatitis B, they might not have the ability to actually rest at home and convalesce. And so often we have to admit patients because they just don't have that ability to convalesce. So as we said, the clinical setting is very important. But I think that looking at that INR is very, very important.
I was wondering if I could just ask a question. I mean, Stephen, Heidi Smuts is on the stage. Anybody can take it. Anna, if you want to grab a microphone. Just maybe maybe just for the audience understanding, this issue, because it was raised about the development of these pre-core and basal core promoter mutations, what in that natural evolution of those development of those mutations then drives the flares that happen in these patients? And I mean, Jeff, you're sitting here as well. Why are these flares so apparent in some people? Is this just a immunological interplay in a given individual? What is it about those mutations that develop in time that drives the flares to be more apparent? Anna, do you want to grab it?
It's working. I don't know if we had I mean, we don't have any longitudinal data, obviously, to know how these mutations develop, but it looks like it's stop codon mutation at the start codon, okay? And it also had the G1862T mutation, which is unique to subgenotype A1, so obviously it was a subgenotype A1. But what could happen is if your E antigen negativity stops suddenly, you know, E antigen acts as a decoy and it diverts the immune response from the liver. Now, if your E antigen is switched off, you don't have the decoy, and now the immune response is directed to the liver. And I think that might have activated the flare.
There's a question from
Professor Lacey?
It's exciting to see acute infections and flare, but there's a lot of talk going on now about hepatitis delta, and I'm just wondering, at what point will we be testing for hepatitis delta in this type of patient? And many people are actually making the point that we're not thinking of delta, so I'd just like your thoughts about, or I'm not sure whether I missed the fact that delta was done or not done.
No, we haven't done Delta. And in fact, so if we look at the prevalence of Delta in South Africa, it's actually very, very low. But obviously, we have a lot of movement down to South Africa, and so we always need to be aware of that. I mean, one of the, obviously, as we all know, is the access to appropriate serology for hepatitis delta, and that's something that we haven't addressed in this meeting either. But certainly, I think somebody we know has got chronic hepatitis, or we know hepatitis B can be co-infection or superinfection, but if you've got somebody with hepatitis D who's otherwise doing very well, and then there's an apparent deterioration, I think hepatitis delta is something that we must consider. And we often tend to forget about it because we have a low prevalence in South Africa.
I wonder, I mean, just a question, I don't know the answer. If you get delta superinfection in somebody who's got baseline chronic HBV, even at a low threshold, would the core IgM come up? Do you think it would come up as well, potentially, or unlikely? Because it's not really a flare, it's a de novo different infection. So maybe the core IgM here would have been the giveaway. I'm just sort of thinking out the box. I have one question, I'm asking lots of questions, sorry Wendy, but it's a good question. Jeff, I think we've discussed it many times on echoes, that alpha fetoprotein that goes up, and it comes down with time, as you show, as it settles. Is it telling you something about that patient? Is he just a constitutive expressor, or is it somebody you really should be paying attention to with HCC screening and be pedantic about it? Not, I mean, everybody warrants screening, but is this somebody that you must make sure that they flagged?
I think there's a little bit of data to suggest that the patients with a higher AFP actually do better. I would have started antiviral therapy in this patient, given that INR, no question. But the AFP is probably an index of regeneration. And as you know, the patients who flare, flares are just typical of hepatitis B. They punctuate the course, and they pathologically have adverse consequences. They can be silent, not in this patient. But it's all about regeneration, and the AFP is probably a marker of regeneration. But having said that, I would have done what you did and started antiviral therapy, not just trusted the AFP to confer a good prognosis.
I mean, I agree. I mean, we definitely treat, but that does give us a little bit of reassurance when you see that alpha fetoprotein being in the hundreds.
They're regenerating a few hepatocytes.
So I mean, often we get questions why we use lamivudine, and Mark and I are sort of quite pro-lamivudine proponents. And one of the things is that when these patients present like this, who are actually have synthetic dysfunction, they're potentially deteriorating, they potentially can develop hepatorenal syndrome. In fact, lamivudine you can actually dose quite easily in renal dysfunction, but importantly, it brings that hepatitis B DNA down very rapidly, and you're not going to run into resistance before 6 months. So our policy is often in these unstable patients to use lamivudine. Once they're stable, bring in the tenofovir, and then you can actually, once they're stable, just drop the lamivudine. But we found it very useful in our setting to rapidly bring down the DNA and stabilize patients.